our Department of Pediatrics update. Today's presenter is Dr. Laura Benjamins in our Division of Adolescent Medicine. Dr. Benjamins received her undergraduate degree from Vassar University, came back home to Wayne State University for her medical degree, and did her postgraduate training, both residency in internal medicine and fellowship in adolescent medicine at Baylor College of Medicine in Houston, Texas. From there, she remained in Houston, where she worked a variety of different positions, including being a medical director for Planned Parenthood, working in the juvenile justice system, working also with HIV positive youth. She's got a wealth of experience, and we're very happy to have her present today on an update in sexually transmitted infections. Dr. Benjamins, it's yours.
Great. Thank you so much. Good morning, everyone. I was fortunate enough in September to attend 2 conferences. The first one was in person. It was the International Union Against Sexually Transmitted Infections. It was a really great experience. There were people from all over the world, representatives from the World Health Organization, and it was the first in-person conference they had since the pandemic had hit. And then the second one I attended in September was the Contraception Technology Conference, which was virtual. And from both of those conferences, I kind of pulled some of the information that was presented. And as I was getting ready for this talk, I realized I probably should have called this more updates in sexually transmitted infections, because I gave an update earlier in the year regarding testing and treatment. And this will go over a little bit in terms of newer updates as far as different testing modalities and other preventive services. So I will share my screen and we'll get started. Hopefully everybody can see that okay. Actually, I'm just going to switch things around here for a second too. Trying to figure out how I can see the chat. Can everybody see my slides okay?
Yes.
And I'm just gonna, there we go. All right, let me get started with the slides. So as far as disclosures go, I have no financial disclosures. There will be some times where I'm going to be using commercial names, mostly for the point of care testing modalities that I'll be going over, primarily because those are the only names that they have. But for ease of familiarity, I will be using some commercial names for some vaccines and medications as well, in addition to the other name for it. Throughout the talk, I'm going to have some questions based on my prior talk, just to kind of test your knowledge and retention. And if you could post your answers in the chat, you'll have a chance to win your very own collection of stuffed sexually transmitted infection microbes that you can see here in the lower corner. So whoever puts the correct answer in first will get a point, and whoever has the most points at the end will get this prize. So the objectives for today are to review new screening and prevention modalities, as well as present research initiatives that I feel are relevant to our patient populations. And then at the end of the talk, I'll be going over misinformation on the internet and how it influences our patients. In progress. So point of care testing, why is this important? Well, first of all, point of care testing for sexually transmitted infections have been endorsed by both the World Health Organization and the CDC for several decades now. However, we haven't had a lot of momentum in terms of making these accessible and ready to use kind of in the real world setting. And I'll go over a little bit where we stand in terms of what is available and what should be coming down the pike. We know that a lot of sexually transmitted infections are asymptomatic, which means that we have this infection reservoir out there that can be very difficult to eradicate, because if somebody doesn't know they have the infection, they're unlikely to go seek treatment. So point of care testing can actually help with this if we're offering that, in the clinic setting to all the teens that we're seeing, for example. And the endpoint for that not only would mean that we're helping to decrease the transmission, but also helps to prevent sequelae like pelvic inflammatory disease and ectopic pregnancy. Another place where point of care testing can be invaluable is in the prevention of mother to child transmission. We have seen that be very effective, for example, with HIV, where oftentimes, especially if a mom has not had good prenatal care, we can do point of care testing for HIV in the delivery room, hopefully before rupture of membranes, and then provide preventative services to that child, hopefully decreasing the risk of transmission in that setting. We have seen a tremendous increase of mother to child transmission of syphilis over the past couple of years. And so this is another area where this would be extremely helpful. And it would also be helpful in terms of helping to decrease the risk of HIV acquisition in knowing that infections like trichomonas and syphilis can actually increase the risk of acquisition for HIV. So being able to test for these things kind of in the moment would also be very helpful. So the World Health Organization has actually put out criteria for what they would consider to be important for point of care tests, and they use the acronym ASSURED, A being affordable, S being sensitive and specific, user-friendly, rapid and robust, ideally equipment-free, which would make it more portable, as well as deliverable to the end users. And several people also advocate for adding R and E to make it reassured as the acronym, R standing for real-time connectivity, and E being ease of specimen collection, but also thinking about environmental friendliness. A lot of the tests that we'll be talking about, there are a lot of reagents and chemicals, but also plastic that are used. And we really want to be mindful of that when we're thinking about the impact on the environment as well. All right, so here's the first question. Get ready to post your answer in the chat. What is the most common reported sexually transmitted infection with rates up to 25% in some populations? All right, Dr. Smitherman got it right. Chlamydia is the right answer. There are some sexually transmitted infections that we'll be talking about in a moment that are more common. However, this is the most common reported sexually transmitted infection. And when we talk about certain rates being up to 25%, for example, at the juvenile detention centers I worked at in Houston, most of the female, we tested everybody for gonorrhea and chlamydia when they entered the detention center, and we often saw rates as high as 25% among the females in those facilities. So as far as what is currently available for point of care testing in the United States, there are several that are available, some of which are CLIA waived, meaning that you can perform them, in your clinic, and some which are not yet CLIA waived. There's only one over-the-counter test available currently for HIV, which is the OraQuick test, and that's actually been available for the past 10 years. As far as CLIA waived testing platforms, there are several that can test for things all at once. So for example, the VISB can test for gonorrhea, chlamydia, and trichomonas all at the same time, which makes it nice that you don't have several different either machines or tests going at the same time. And there are currently 8 point of care HIV tests, although there's only one that includes the P24 antigen. Point of care tests for HIV are usually antibody based, which means that they're not great for acute HIV detection. Adding the P24 antigen helps us to detect HIV a little bit sooner than antibody testing alone. And it's similar to what is in the 4th generation HIV test that we do for screening. So I just want to give you a sense of what these different tests look like. Some of them are quite large, about the size of a printer, and others are smaller, like the handheld VISB that tested for the gonorrhea, chlamydia, and trichomonas. And some are lateral flow tests, similar to a lot of the COVID tests that are out there right now, which make it pretty user-friendly. You add a reagent to the swab, you put that liquid in a little dish that has a stick, and as the fluid moves up, it's kind of like a pregnancy test, tells you positive, negative. And as I mentioned, a lot of the COVID tests are like this. But I wanted to show you this because, ideally at some point, if we're utilizing these in our clinic, you can imagine that if you have one large printer size platform that tests for gonorrhea and another one that tests for chlamydia and another one that tests for trichomonas, you're going to run out of counter space pretty quickly. So ideally we want these things to be smaller and a little bit more user friendly. I just wanted to give you some information also about the sensitivity and specificity of some of the rapid HIV tests. You can see that these numbers are quite good. However, this is not for acute HIV. These are based on tests that were done and studies that were done on people who have already been known to have HIV. And the reason that these are not good for acute HIV, as I mentioned, these are testing mostly antibodies, except for the one test that does include the P24 antigen. And we still have that window of time where a person may be infected, their viral load may be going up and detectable by RNA PCR, but they have not yet developed the antibodies. Adding that P24 antigen does increase or decrease the amount of time to detection by a couple of weeks, but still you're going to miss those that have acute HIV potentially if we're just using this. Again, just wanted to give you a kind of sense of the timeline of these different tests and the length of time that it's been taking to kind of develop them, as well as the turnaround time and sensitivity and specificity of some of them. There have been multiple studies looking at how long a person is willing to wait for test results, and usually it's less than 20 minutes. And you can see we still have a ways to go in terms of improving that turnaround time for a lot of these tests, with some of them being up to 2 hours. So for point of care tests, you really want to be able to have that result available while that person's in clinic, because if they need treatment, then you can also offer that to them at the same time. But if you're waiting 2 hours, that's going to make clinic flow very difficult, as well as make our patients very impatient. So depending on what test modality you're using, you may need to rethink the workflow, and that maybe a person, as they're being groomed, submits a sample or a swab, and so that's cooking while you are seeing the patient and have the result ideally at the end of the visit. But again, some of these times are just way too long. One exciting thing or good thing that I think has come from the COVID pandemic is because there was such a rush to develop rapid tests for COVID, this kind of really pushed the envelope or kind of pushed the timeline for a lot of these companies to come up with platforms to provide rapid results for COVID and flu as well, as you can see. So at the x-axis, you can see the turnaround time going from 30 to 90 minutes. And then on the y-axis is the sensitivity. Ideally, you want something kind of at that intersection where the sensitivity is high, but there's a short turnaround time. You can see there are multiple companies that have come out with these various platforms, and the ones that have the solid circle around them, these tests have already pivoted to be used for sexually transmitted infection point of care testing. And those that have the dotted line are those that are in progress. So in a way, the COVID pandemic has really kind of increased the turnaround time and kind of helped us get closer to having some of these things available for sexually transmitted infection testing. All right, second question. I am the second most commonly reported sexually transmitted infection in the US. My rates have been rising and I'm becoming more resistant to treatment. What am I? Oh, somebody already got it. Although it just says Mac. I don't know who specifically answered it. All right, Dr. Marshall. All right, so 1 point for Dr. Marshall. Besides point of care testing, one of the other things that I want to review is the option for mail-in testing services that are offered for various sexually transmitted infections throughout our country. And this map shows you where these services are available by the state. So those that are darker blue or gray have up to 12 different type of mail-in testing services available. And those states like New York, unfortunately, that are almost white, don't have any. So you can see there's just really a wide array of what is available. The dots represent specific programs, one of which I Want the Kit I'll be talking a little bit more in depth about in a few minutes. So in terms of making testing available to our patients, there was a paper that came out not too long ago, just last year, in terms of what we really need to do to make direct-to-consumer testing services widely available. Ideally, you want a quality feedback system that is national and that is easy to use. You want to be able to provide FAQs as well as information about testing sites and have it available in different languages. You need to be able to be aligned with guidance from leading public health officials as well as medical organizations. Oftentimes, state regulations and licensing and accreditation requirements can be barriers to providing these services. So maybe looking at those and how to revise them to make these more accessible. Absolutely critical to be able to utilize your local health departments as far as linkage to care. So making sure that that conversation is started early, as well as making sure that there is national guidance as well as recommendations for validation and verification of ship samples are just some of the things that are really important to think about. Our patients can also find out where the services are available by going to gettested.cdc.gov. And so as an example, I put in the zip code for our clinic location. And as you can see, there are some mail-only self-testing options available here in Detroit. All right, next question, true or false? Expedited partner treatment is legal in Michigan. All right, 400 Mac got the next one right as well. It's true. Expedited partner treatment is legal in Michigan. This is something we talked a little bit about before the last time I presented. And basically what expedited partner treatment is the ability to provide medication for a partner or partners without having a clinical experience with them. So you do not have to have seen them in person in order to provide that medication. And as of 2022, almost all states do allow this, including Michigan. There are a few where the laws are not specifically clear, so it's probably allowable. And there are no longer any states where it's prohibited, which is good news. Actually, Michigan used to prohibit it, but it is now legal to do this. So shifting gears a little bit, the next thing I'll be talking about are vaccines. Currently, the only vaccine that is widely available for a sexually transmitted infection is the HPV vaccines. But you can see there are a bunch of them that are hopefully going to be available sometime in the near future. There are ones looking at gonorrhea and chlamydia, as well as HSV. Hopefully we have one for gonorrhea soon, as we're seeing increasing rates of resistance to different antimicrobials. And so it's going to be really important to have other tools in our pocket to help prevent infections like gonorrhea, since it's becoming so resistant. Some good news, though, is that we are seeing things that are very effective. So, for example, there is a lot coming out in the literature about the effectiveness of the meningococcal B vaccine, also known as Bexsero, actually providing some protection for Neisseria gonorrhea as well. And that's because they actually share the outer membrane vesicles. And so there's been some observational studies so far looking at both cohort and case control, looking at teens and young adults who have received this type of meningococcal vaccine. And they have seen significantly decreased rates of Neisseria gonorrhea among those vaccinated with this vaccine. So that's really encouraging. Also encouraging is some recent data looking at the effectiveness of the HPV vaccines. We're seeing a tremendous decline in vaccine type prevalence of HPV among females rates as high as 88% for females 14 to 19 and 81% for those 20 to 24 when we're comparing to years before the vaccination. Another thing that's come from the COVID pandemic is looking more at using the mRNA vaccines for different infections. And one that has been looked at recently is a trivalent mRNA lipid nanoparticle vaccine against HSV-1 and 2. And at least in animal studies looking at mice and guinea pigs, it's been very effective in decreasing genital disease, at least short term. So that's showing some promise as well. All right, next question. Which sexually transmitted infection has a lifetime prevalence of 80%, greater than 80% probably? Let's see who got it first. Dr. Mazar got it first. HPV is correct. So as I mentioned before, not only are we seeing decreased rates of the HPV strains that are associated with the vaccines that we have for that, we're also seeing decreased rates of pre-cancer, cervical precancer rates, as well as some evidence of decreased cervical cancer risk as well. So this study that was published a couple of years ago from the HPV Impact Project shows you the tremendous decrease in cervical precancer rates among women screened during the time period, 2008 to 2015. And in Sweden, because they've had a very robust vaccination program there since 2007, they're actually seeing a tremendous decrease in terms of the risk for cervical cancer, especially if somebody is vaccinated before they're 17 years old. And I think this just really highlights how important it is for us to advocate for this vaccine for our younger patients. And luckily, rates of vaccination for HPV are increasing. So I just wanted to show you 10 years ago compared to now. So back in 2012, the vaccine had been around for about 4 years at that point, at least indicated for females. And you can see the vaccination rate of completing all 3 doses at that point was just about 30%. So, really lagging behind the other vaccines that we typically recommend around 11 years of age with the Tdap and the Menactra. And then in 2011 is when the vaccine was recommended for males as well. So luckily, vaccination rates are much higher. And there were also changes in terms of recommendations that if you start the vaccine before the age of 16, if you started at 15 or younger, you only need 2 doses. So that also helped to improve completion of this vaccine as well. And you can see rates are now as high as about 60%, although we still have a long way to go. And another thing to think about is that the pandemic has also happened since a lot of this data has been collected. And just this week, I had 2 12-year-old patients that had not received their 11-year-old shots. They had not received their first dose of HPV yet. So I think we're going to be seeing a lot of catch up with these vaccines as well. We're also seeing a lot of disparities in terms of coverage for the HPV vaccine. So depending on where you live can impact whether or not you're fully vaccinated. And you can see that if you are in a mostly rural area, you're less likely to have been fully vaccinated against HPV, but also less likely to be fully vaccinated against some of the other infections that we vaccinate against. So what are some factors that can improve vaccination rates? A recent study looked at whether or not a provider provided information on the HPV vaccine, as well as made the recommendation for a patient to be vaccinated. And vaccination was much higher among those patients reporting that they got a strong recommendation from their provider. So really important, again, to understand our role and to make sure that we are advocating for this for our patients. If you also look at reasons for not vaccinating against HPV, the number one reason is still concern about safety or side effects, However, you can see there's still a large percentage of patients who reported they didn't vaccinate their child because it wasn't recommended to them. I also want to comment briefly about the safety concern. This vaccine has been around long enough that we know it is very, very safe. It's just as safe as other childhood vaccines that we recommend. So you can reassure your families about that as well. All right, we're going to be shifting gears a little bit. So our next question, youth age 13 to 24 years old accounted for more than blank and blank new HIV diagnoses in 2019. And I'll give you a hint, these numbers are less than, both numbers are less than 10. So what out of how many were new HIV diagnoses among this age group? You can also think about what percentage of new diagnoses are in this age group and kind of work backwards from there. Dr. Smitherman said 4 out of 10. Jen said 1 out of 10. You guys are close. One out of 9 I saw as well. And no, it's actually, I'll go ahead and give you guys the answer. And I think Dr. Smitherman was probably the closest. So unfortunately, oops, sorry, lost my cursor there. It's actually 1 out of 5. So youth ages 13 to 24 represented over 20% of new HIV diagnoses in 2019. And the reason I bring that up is I now want to transition and talk a little bit about PrEP, or pre-exposure prophylaxis, because it really is an essential tool to ending the HIV epidemic. And as pediatricians, keep in mind that 1 out of 5 new diagnoses are in patients that we will see. So in terms of the age group. So for those of you not as familiar with pre-exposure prophylaxis, it's a medication that can be used daily, although there's an injectable that I'll be talking about in a moment that dramatically reduces the risk of acquiring HIV through sex or other modalities. And there we have seen an increase in the use of PrEP over the past several years, especially among men that have sex with other men. It's gone up from 6% to 35%. However, that's really way too low still. And especially among Black and Hispanic men that have sex with men, we're seeing much lower uptake rates. And those are the patients that end up having the highest risk. So what we can do as providers is make sure that we are routinely testing for HIV. The CDC recommends starting at age 13, regardless of risk, and then testing annually based on risk after that. And so what I do with my patients is I really try to normalize it and tell families that this is a routine test that we do with all of our patients. I have a letter that explains that as well, that they can read if they're new to our clinic, just so that they know when they see that test being done, that it's not because necessarily their child is doing something, but that we're just doing what is recommended for patient care. Also really important to assess patient risk. So that means asking those delicate questions, asking about sexual risk behaviors, as well as potentially IV drug abuse as well. Although I'll be honest, among the patients that I usually see, I don't have a lot of teens that are IV drug abusers, but some young adults. And you always got to ask because you just never know. And then to be familiar with what your options are in terms of prescribing PrEP. And we're lucky here at Wayne Peds in that we have Horizons Clinic right down the hall. So while we are seeing some improvements, it's definitely not where we need things to be. We need at least 50% of patients at risk of taking PrEP to really have an impact on the HIV epidemic. And you can see we're doing quite well among white patients, but not so well among Black and Hispanic patients. And similar, the data that this came from, the same survey showed that among transgender women who are probably at some of the highest risk for acquiring HIV, although 92% were aware of PrEP, there was only about a 32% uptake. So we still have a lot to do in terms of educating and advocating for this as well. The CDC also has some very helpful flowcharts in terms of trying to figure out who is eligible for HIV PrEP and who we should be talking about this with. But basically, anybody that has a lot of partners, condomless sex, has had multiple STIs, these are really patients that we should be talking to and having discussions about starting PrEP. And again, it really means asking those questions, not only about vaginal sex, but about anal sex and how many partners and how often are you using condoms. So just really getting comfortable with asking those questions on a routine basis. Again, also asking about history of injected drugs as well. Another thing that the United States Department of Health and Human Services has done is recently has tried to enhance mail order delivery options for PrEP. And you can go to the Ready Set PrEP website to get more information about this. And this is a way that a patient can coordinate getting tested and then receiving this medication through mail. Excuse me. I also want to tell you briefly about some things that are also in the process of being developed and where there's funding, researching long-acting HIV prevention. And I'll be talking in a minute about one that is currently available as an injectable, but some other things that are being developed are using a polymer ring, similar to what we see with contraception, for example, there's the Nuva ring, which has estrogen that is secreted and is changed once a week. And as of this past year, there's actually another ring available that's good for a whole year. So a woman can use the same ring. You take it out periodically, you don't leave it in for a whole year, but you can use the same device for up to 12 months, which makes it a lot easier than having to go back to the pharmacy every month to get a new one, or to get your new set of rings. Also, many of you are probably familiar with the Nexplanon implant, which is a little rod that is inserted and it releases etonogestrel, which is a progesterone, over the course of several years. FDA just recently approved that to be used for up to 5 years. Previously was for 3 years, but it's been found the progesterone is secreted at levels high enough for up to 5 years to prevent pregnancy. So similar devices are now being looked at to potentially have antiretrovirals that are secreted over time, which would obviously enhance adherence because the patient doesn't have to remember to take a pill every day or to go to the clinic to get an injection. And then lastly, there are also some studies looking at antibodies that are infused or injected into the body as well. So at the end of 2021, FDA approved a long-acting form of cabotegravir, which is an integrase inhibitor, as the first and only long-acting injectable form of PrEP. So this is something that is injected after a lead-in interval every 8 weeks, every 2 months, and you have a window of 7 days. So you can give it 7 days earlier or 7 days later in order to maintain effective levels. But it was actually found to be very safe and actually more effective than daily oral PrEP. Because as you can imagine, it's much easier. Well, you don't have to remember to take a pill every day if it's an injectable that's staying in your system for a long period of time. What was interesting too is that they actually had a large study looking at cisgender women who were at risk, and it was significantly more effective than oral PrEP for reasons that are a little bit different than for males, in that for oral PrEP to be effective in males, usually you have to take about, you have to make sure that you're taking your pill at least 4 days out of 7, 4 to 5 days, whereas women, for it to be effective, you really need to be taking it daily, 7 out of 7 days. So much more difficult. And that's probably due to concentrations of antiretrovirals in the vaginal mucosa. But if you have an injectable, you don't have to be worrying about remembering to take something daily. It makes the concentrations much higher and therefore more effective. How to get this fund if we plan research? I'm sorry, I'm just reading a question in the chat about, so funding to look at research regarding this at a hospital in Pakistan. I mean, you would be having to apply for NIH funding, basically, or looking at other funding sources that would look at using these different modalities, but some of them aren't available yet for studies like that. All right, our next question. One study among men that have sex with men found that rectal Neisseria gonorrhea to be asymptomatic and what % of the time? I thought about adding like Jeopardy music while we were waiting, but I couldn't figure out how to do that. So I see B, I see 26%. Any other guesses? 58%. All right, so nobody got the right answer. It's actually 84%. So this again just highlights how important it is to be screening patients regardless of symptoms and more based on what their risk factors are. Okay, another question. Another study found the percentage of gonorrhea infections missed among asymptomatic men that have sex with men if you do urine testing only is what %? So what percentage of infections are we missing if we're only doing urine among this population? Yay, somebody got the right answer, 400 Mac. So, sorry, yes. So this one study found that among asymptomatic men that have sex with men, if you only do urine screening, you're going to miss 95% of gonococcal infections, Neisseria gonorrhea. Again, just emphasizing how important it is to talk to our patients about what their risk factors are, what their exposures are, and not to forget to ask about and offer extragenital testing for these infections, especially since most of the time they're going to be asymptomatic. They're not going to know that they have it unless they get tested. So this brings me back to mail-in options for sexually transmitted infections, because this is a way that patients can actually do extragenital testing in the privacy of their own home. So as an example, I wanted to go over I Want the Kit. The lead investigators for this project presented a lot of their data at the International Union Against STI conference that I went to. And I encourage you to go to their website because they have a really nice user-friendly website that has a lot of great information. Currently, this is only available in Alaska, Oklahoma, Arizona, and Maryland. But I think it's a really nice example of how we can offer these tests to our patients in a way that they might be more comfortable with. So I know this is a busy slide, but I just wanted to give you an idea of what information they have there. So they have this nice table that kind of goes over what kit do I need to order based on what type of sex they had in the past 3 months. It also goes over important information in terms of how old you need to be. And it differs depending on what type of test you're ordering. Specifically, if you're ordering HIV for this particular project, you need to be 17 years or older. Talks about, also if you go to the website, it goes over information about confidentiality. It shows you pictures of what the box or the envelope will look like when it comes to your house. You don't have to be worried about it screaming STI testing on the outside. It just has a lot of really nice information. So what they presented at the conference was what they had to do to kind of pivot and expand their network during the COVID-19 pandemic, since we were seeing less face-to-face interactions. And we know that people were not coming in for STI testing. They really were proactive to make this more readily available to a larger population. And a key piece of all of this was really working closely with their local health department, especially for linkage to care. So I don't have a slide on this, but what they presented at the conference, that they had actually over 90% linkage to care for those with positive test results, which was just really impressive. And also shows you the tremendous uptake in utilization of this program during the pandemic, again, just because so many people were not going to see their doctor. So I think there are a lot of lessons that we can really take away from all the kind of innovative things that were done during the pandemic. Another thing that I want to emphasize is the importance of allowing patients to do self-collection. So this was a meta-analysis systematic review looking at different studies that looked at self-collection of samples for sexually transmitted infection testing. And what they found is that participants that were allowed to do self-collection for these tests were 3 times as likely to get tested for any sexually transmitted infection. So allowing our patients to do this will greatly increase the chance that they will be tested. And before I go to my last few slides, where I'll be talking about misinformation on the internet, I just want us to take a few minutes to think about the resources that we have available to us here in Detroit. We have our health department, the STI clinic, we've got Corktown, Horizons, Toland, Wayne Health, Wayne Peds. You know, what things can we do to kind of maybe bring our resources together and maybe think outside the box about how to deliver some of these testing options to our patients? I have a picture of a drone here because one of the posters at the conference was looking at using drones to deliver testing kits to remote areas in different countries in Africa. And while I don't think we necessarily need to go to that extreme, we do have the option of maybe a mobile health unit going to different places, bringing the testing to the patients where they are, as opposed to expecting them to come to us, which coming to us, there's all kinds of barriers. There's transportation barriers, there's time off of work or school. So, you know, again, maybe at some point in the future, we can really put our heads together and think about what are some of the things that we can do to expand our testing capabilities and availability for our patients. What's Up Outreach offers mail-in testing for HIV. Yes. And thank you, Dr. Secord. That was something at the beginning when we talked about being able to find where you get mail-in options for testing. When you go to gettested.cdc.org, it did bring up the Horizons project, and I didn't specifically mention What's Up, but that's really good to know as well. So thank you so much. I also forgot to mention earlier, as far as the injectable for PrEP goes, the cabotegravir injection, Horizons will be embarking on a study soon called the Ebony Project, where we'll be enrolling cisgender and transgender women to look at the uptake of this injectable, and the infusion center here they're supposed to have some doses available. My understanding for the cabotegravir injectable for PrEP, it's actually fairly easy to get it if your patient has Medicaid, but if they have private insurance, it's been a little bit more difficult for a lot of practitioners to obtain this. Now, in theory, because of the Affordable Care Act, which states that insurance has to pay for preventable services, since PrEP is a preventive service, it is supposed to be covered by private insurance as well, but it's just taking a little bit of time, since it was just approved a year ago, for that to actually come to fruition. All right, so the last thing that I'm going to talk about in these few minutes that we have left is just the impact of social media and some of the misinformation that's out there and the impact that it has on our patients. So as of January 2022, you can see what the most popular social media platforms are. And even though Facebook is listed as #1, if any of you have any teenagers at home or college age students even, I know my college age student will tell me, oh, Facebook is for older people or for old people. I think most of the younger folks that we see are more likely to be using things like Instagram or TikTok. This also just shows you the tremendous uptake of these different technology modalities since they've become available. You can see that while millennials lead in terms of technology adoption, Baby boomers and Gen Xers are also heavy adopters of owning a smartphone or having a computer or utilizing social media. I'd say most of us do all of these things. And I bring this up because not only are these platforms where misinformation can be spread, they also can be platforms to reach our patients, to provide them accurate information, and to let them know about what things are available to them. So it can be a really powerful tool. You can see what percentage of people you can actually reach through these different modalities. So some other statistics to kind of contemplate: every minute, there are 5.7 million Google searches, close to 700,000 hours streamed on YouTube. There are 167 million videos watched on TikTok, 575,000 tweets, and 44 million Facebook Live views. I mean, these numbers are just staggering. 70% of TikTok users are that age group that are also very high risk for HIV, acquiring HIV as well, or sexually transmitted infections. So again, just I put this out there to think about how can we reach our teens and young adults with good information. On average, this is all age groups. We tend to spend over 2 hours a day on social media. It's just a huge amount of time. And the thing, though, that's most scary to me is that younger age group, the 18 to 24-year-olds, in one study, it was found that 90% of them would trust medical information shared by someone they know on social media. And I know I've had this experience, and maybe some of you can relate, where a relative or friend of mine, they're disputing what I'm telling them as a doctor, or saying, oh, no, I saw on Facebook that my friend had this side effect, or that they had this complication from a vaccine. And that, unfortunately, has a much more powerful effect sometimes on their decision-making than the information that we're providing. And so these are just some examples of some of the misinformation that's out there. You can find natural remedies to treat sexually transmitted infections, as well as natural cure for HIV and AIDS. There are, unfortunately, medical professionals spreading misinformation on social media as well. One of the reasons I put this TikTok here is I think there's also, this is representative of a lot of the mistrust that people have of the medical industry. You can see here, hashtag big pharma problem. There really is, for a lot of people, a mistrust, and that's something else that I think we need to focus on and figure out how to address. And another thing I wanted to point out also is that a lot of the social media that focused previously on complications or side effects of the HPV vaccine has now focused to those who are against the COVID-19 vaccine. So it's kind of spread over. These are some examples of how to counteract what's out there. At the Contraception Technology Conference that I attended, Dr. Jennifer Lincoln was a presenter. She's an OBGYN that posts nearly daily TikToks with accurate information. And she's kind of made it her mission to make sure that there is information available to the younger users that's accurate and dispels a lot of those myths. And she makes these, I really encourage you to look at what she does, because she's made them fun. I think an important key piece of getting information to younger patients also is making the information brief. A lot of these TikToks are very short. And she really does a really great job of making her message effective in that media. The CDC, the World Health Organization, they have Twitter accounts, they're on Facebook. So that's another way that they can get their information out as well. And I also found this recent study looking at HPV vaccine messaging on TikTok, and they did an analysis of kind of social media content. And while most TikToks that they reviewed were pro-vaccine, the anti-vaccine TikToks unfortunately had more user interactions. And I don't know if that's because they were more provocative or more fun to watch, but I think there are things that we can learn about how to make our information meaningful and accessible to our patients. And while cancer prevention was the main content areas for pro-vaccine TikToks, the primary focus of anti-vaccine messaging focus more on like the side effects or possible bad things that could happen, which makes sense. And about 30% of all top TikToks were developed by health professionals, which means the majority of those out there were not at all developed by health professionals, which is a little bit concerning too. All right, so wrapping up, I do want to leave a few minutes for some questions at the end, but I also, in addition to conclusions, want to leave you with some questions to kind of ponder and think about. So as I went over, there are several new point of care tests available in development that hopefully will be available soon. But once they are available, how are we going to utilize them? How is that going to impact our clinic flow? How are we going to integrate that into our care? And there are several vaccines in development as well, but how are we going to advocate for them? You know, I already know so many of my patients have vaccine fatigue, especially with the COVID vaccine. They're like, really, another one? So it can be really hard sometimes to advocate when our patients are just tired of getting another vaccine and another vaccine. So I think we need to think about in advance, how are we going to really make sure that our patients have that information available to them to make those decisions about those vaccines. We have several options available for PrEP. Who are you going to recommend it to? And again, that means asking those uncomfortable questions and really making sure that we're screening all of our patients for those risk factors. Several studies have found extragenital testing and self-collection to be beneficial. How are you going to offer those to your patients? And there's so much misinformation out there. How are you going to, what are you going to do to help counteract that? I think the biggest take-home message overall is to make sure that we are asking those difficult questions and that we are taking our time to advocate for our patients and to make sure that we're giving them accurate information so that they can make healthy decisions to stay safe and healthy. All right, last question. Who was my daughter for Halloween? I don't know if there's any Disney fans out there. Not seeing any answers yet, so I'll just go ahead and sake of time. She was Mal from The Descendants. If any of you don't know about it, don't worry, I wouldn't recommend the movies. They're pretty awful. All right, well, thank you so much for your time. If you have any questions, please feel free to reach out to me. If at any time you also want any information or advice regarding a patient, please feel free to reach me on my cell phone as well. And with that, I'll stop sharing and take some questions.
And Laura, thank you very much. This is Dr. Martin Toby. It was really a great presentation. I really enjoyed it. I'd like to learn a little bit more about the meningococcus B. Meningococcus is a very, very difficult organism to deal with. It changes its antigens all the time. And that's why people get multiple infections with it rather than, getting immunity. Now, you mentioned that there is a vaccination. I was just wondering how durable it was because, it's very complex. There are opacity proteins that actually are the effectors. They hook onto a CCAM1 receptor, a complicated set of things that have to occur. So I was just wondering, how exactly do we get a effective vaccine against the meningococcus B group?
Yeah, that's a great question. I'll be honest, I don't know if I can answer that very well. Most of the studies that I found as far as the meningococcal B vaccine goes were mostly observational at this point, cohort or case control. I'm not sure. And Dr. McGrath, I know you have your hand up and you might actually know more than I do about this. But I couldn't find any randomized controlled trials yet. I don't know exactly in terms of down the line how to make it more effective. I'm not sure. Dr. McGrath, do you have any ideas or any more information about that?
Just that they didn't actually do that study to look at that.
Right.
They did they went back after they had a concept of a trend and they went back and looked at the data. So even that relatively recent report is not was not done as part of a study specifically looking at it, but I know on the one hand we have a good number of patients who took the Bexsero, and I fear, what if we hadn't used it? How much more gonorrhea would we be seeing? Which, as the crew of Horizons knows, we see a ton of it already. And so I'm happy to have used it in the patients we had it for. I hope we can get it again soon back in the clinic. But I think a real, a focused trial on it would be the best, way that they could really make some inroads with seeing if it's possible to cover both. I mean, we don't really see disseminated gonorrhea very frequently. Most of the time, it seems to be pretty much localized to an area. It's always a risk factor, I guess, of, I mean, again, the vaccine was there for Neisseria meningitidis. It's sort of a lucky bonus that we're getting any coverage at all of gonorrhea, but it would be great if they could do more or look more into it. I think they probably will in the future, but right now they're, they just have the retrospective sort of back look at the study.
Right.
The only thing I wanted to add, why I raised my hand, was just a separate side note. I think about the flu shot and the COVID shot. This is the time of year we're always, asking the patients to either accept it or not, or offer it to them. And the problem is, I thought maybe if we just put the vaccine information sheet, laminate it and just leave it in the rooms for people to look over. But as I review it myself, even the CDC puts on there, as with any medicine, there's a very remote chance of a vaccine causing severe allergic reaction, serious injury, or death. So, I think in their efforts to have like a full disclosure with the BIS forms and try to put it as simply as they can, when they add that little caveat, it's like, even if we tell the patients over and over how rare it would be, or, but this says it can cause death. Oh, great. So, it's just hard to think it's really gonna, convince somebody who's on the edge. What I see more likely now is we offer it to everybody, and we probably should just have a party. I was talking about getting a cowbell yesterday, when anybody actually accepts it, or the COVID shot, and just, celebrate it, at least in our clinic, if not throughout the whole clinic, whenever anybody decides to do it. But I would like the patients to know that we're doing it too, because, the way the clinic's designed, we would all hear the noise, but the patient wouldn't realize, what the heck are they doing in the back there? So I'd want them to be involved too. But yeah, we definitely have to look at hesitancy. It's really impacted broadly the patient's acceptance of, I think, all vaccines at this point. Even the ones that we used to think were just routine and everybody would get them, some of that's even being in question now. So I'm really worried about it for the future.
Yeah. And it'll make it more difficult when some of these vaccines are available for STIs to have uptake. I think there'll be a lot of hesitancy as well.
Yep.
Dr. Smitherman?
Yeah, I wanted to piggyback on what Dr. McGrath said. I truly agree that since the pandemic, the acceptance of all vaccines has pretty much gone down quite a bit, with a lot of the misinformation that you mentioned that's out there regarding, normal vaccines that our parents have had and are still alive to talk about it, and are still really hesitant about getting their children immunized. And my concern is down the road, as we're developing new vaccines, I know hopefully, and I know this is on a different topic, like RSV vaccine, hopefully down the pike will be available within the next year or so. Families are looking at all of these as new. And so I think we also have to think about rebranding how we approach our families and how the information gets out there to the general public about the importance of the diseases are not new, but our ability to prevent them is new, and that's what we're looking for.
Absolutely. All right, well, it's a little after 9, so I think it was a tie between the 400 MAC group and Dr. Smitherman, so you guys can maybe divide up the little stuffed animals if you want, but I'll bring this down. So thank you all for your participation and for your time. And as I said, if you have any other questions going forward, please don't hesitate to reach out to me.
Thank you very much, Dr. Benjamins, and thank you everybody for participating, and have a great day.